So, good morning and a very warm welcome to everyone on seminar, which is being hosted by the NIHR First Teams, and it's the seminar on capacity building in collaboration with local authority and partners. And I'm Rona Campbell, and I'm director of one of the 6 First Teams. I'm director of First Insight. And capacity building is a very important activity, and in my long academic career as a health researcher, it's one I've devoted a considerable amount of time to, and so I'm very much looking forward to this seminar. And I tend to conceptualize capacity building as being a bit like managing a communal garden. It needs constant work, and it's good to have a plan to work to, and you need a variety of plants, which will have different roles, and some will take longer to mature than others. But when you've put in effort, you get very rich rewards. But everyone may have a slightly different view of what a good garden looks like, and what's best. And when people are very busy or resources are constrained, things can get a bit neglected. But the good news is that's very definitely not what's happening in terms of the NIHR and capacity building, because there's a considerable and sustained focus on capacity building, particularly where public health research and local authorities are concerned, as we are going to see this morning. So if I could have the next slide, please, Cobus. So this is our timetable. And for those of you new to the work of the First Teams, James Morris is going to undertake a brief introduction to the work of our First Teams. And this is going to be followed by a presentation by Dr. Jo Williams, who's a consultant of public health in Bristol City Council and a senior lecturer in public health here at the University of Bristol. So she's very well placed to provide her thoughts on the opportunities and constraints on research capacity development and local authorities and how this relates to first evaluations. And then we're going to have 4 presentations about different approaches to capacity building that are being used in our first evaluations. And threaded throughout the seminar is time for questions and some discussion. And we also have a comfort break built into that. If I could have the next slide, please. So just a few housekeeping notes before we get underway. First of all, there are more than 100 people attending this seminar, so it's not possible to have verbal questions. So if people pop questions in the chat function at any point, we will address those questions in the discussion session. Could I ask everyone that unless you're speaking, to keep your microphones on mute so that we don't get background noise? And speakers, if you could please keep your cameras on when you're speaking, and in the discussion sessions. All other attendees can keep their cameras on or off as they prefer. And during the comfort break, I suggest that we all mute our microphones and put our cameras off just during that time, rather than going in and out of the meeting and leaving the room. And as you will have hopefully already noticed, we are recording the session so that we can make it available afterwards on the First Teams website. So, that being said, it's my absolute pleasure to introduce Dr. James Morris, who's a consultant in public health medicine and who works with the NIHR directly on work of the First Team. So James, over to you for your introduction.
Thank you, Rona, and good morning, everyone. And just to echo Rona's warm welcome to today's seminar. By way of introduction, I've just got 3 slides just to set the scene. I'm sure the content is going to be pretty familiar to almost everyone on the course. So I'll keep these remarks fairly brief, but Cobus, if you could move to the next slide, thank you. So just a reminder really just about what the first scheme is all about. So FIRST stands for Public Health Intervention Responsive Studies Teams. And at the moment, we've got 6 fantastic academic first teams who are fully funded and ready and waiting to evaluate local government initiatives. So the model of the scheme is that local government teams can propose initiatives to the first scheme for those initiatives to be evaluated. And then those evaluations are co-created in partnership between the first team and the local government team. And the primary aim of the first scheme is to build up the evidence base for local government to inform future decision making around health related issues. But as a happy consequence of that, the first team, the first scheme has been fostering, mutual learning and building research capacity within local government, which brings us really to the content of today's seminar. Next slide, please, Cobus. Thanks, Cobus. So as I say, we've currently got 6 first teams spread across the UK. They're listed on the slide there. The map on the right is showing the locations of the interventions that we've currently got on the books and that are being evaluated. So we've currently got over 30 interventions at different stages of evaluation. And next slide, please, Cobus. And just finally, by way of just putting this in context, really, I thought it was worth mentioning another initiative of the NIHR, which is in some ways hot off the press at the moment. So the Health Determinants Research Collaborations, or HDRCs. 10 and moving up to 13 of these collaborations have recently been announced and are getting going. And the aim of HDRCs is to develop the infrastructure needed in local government to enable research to take place. So obviously there's a link here with building research capacity in local government, which is why I'm sort of mentioning this now. As I say, these collaborations are just getting going, and the aim is to boost local government capacity and capability to conduct high quality public health research to tackle health inequalities. So I think there's an interesting dynamic going forward, I think, between the first scheme and the HDRCs. So that's all I was going to say. So if I can hand over to our next speaker.
Great, thanks very much. Just to introduce myself, my name is Jo Williams. I work at Bristol City Council as a public health consultant and as the academic lead in the public health team there. And I've had the great privilege of being involved in First Insight over the last year or so as it's developed as in part of my role as a senior lecturer at University of Bristol. So I'm just going to talk a little bit about some of the constraints and challenges we have in local authorities, but also perhaps some of the lessons that we've already been able to learn from First as ways forward and that we'll be exploring further in this seminar. So Cobus, could you move on to the next slide? Many of you will sort of join with me in appreciating what a huge opportunity First is for local authorities. We of course have a shared goal between academic and service public health to improve health and wellbeing outcomes and reduce health inequalities. And a really important element of that, of course, is building the evidence base about which interventions are both most effective and most cost effective. And I think the need to demonstrate value for money is increasingly important in the current context. So the economic evaluation elements. In local authorities, we have unique partnerships and context for each local authority. And I think one of the values of First is how unique it can be for each specific area. Interventions constantly needing to be adapted to local needs and context. Huge numbers of new ideas generated by partners, by communities, and by public health teams. So it's really welcome that this opportunity is in place. And of course, already mentioned constraints of funding, so the opportunity of evaluation being fully funded. I guess the other opportunity here is the connection to voluntary community sector organisations and to communities. And I guess as we think about capacity building, we're thinking partly about public health teams and local authorities, but the partners as well have a real interest in capacity building, particularly in voluntary sector organisations. And certainly we've got experience of research led from communities and led from community organisations. Can I go on to the next slide? I just wanted to bring in early on about, I guess, that we're not working from a blank sheet in public health teams, that both there's an official framework for training and development, and there's an appreciation of the need for research skills in local authorities. So I've put here just a part of the public health skills and knowledge framework that's on the government website. There's an element of that framework that is about research skills for all public health practitioners, which, as you can see, is about both how you develop the evidence base and how you use it in your public health practice, covering understanding sort of evidence reviews, critical appraisal, about research design, how you use evidence in practice, identifying gaps in the evidence base, and so on. So just so you're aware, that framework is in place, and teams are working to these, building up these knowledge and skills in their practice. So just move on to the next one. I've pulled out, I guess, some of the constraints and challenges. These will be very familiar to any of you working in local authorities, and I'm sure first teams working with local authorities have observed these challenges. First of all, the workload, increasing, I would say, pressures on people's times in local authority, not least from pandemic context, but also from budget constraints. So I guess that has a huge impact on, first, in terms of time to put in applications to support projects. And I guess we don't know which projects never reach first. I mean, I know in my own authority, I have a long list of projects that could go forward, but the time to put those forward is quite constrained on the team. I guess the second one is around language. We often create some distance between academic and service public health with our acronyms. I've used some here from local authority side. We've already used some from the academic side. So acronyms and terminology can build up real barriers and lead to lack of engagement in research. Without a translator, and I've put that in because in this seminar we're going to talk quite a lot about embedded researchers, and I think there's a huge opportunity having someone who can translate the language back and forward, working with teams. Timescales is a constant challenge. We in local authorities, we have both regulatory constraints, but also future uncertainty over budgets and the need to spend in year, which obviously is a mismatch with the first evaluation timescales. Constant change. I'm sure any of you working with local authorities from first teams will see constant change in roles, policy, priorities, leadership, budgets, and that will impact on capacity building as well. So how we sort of ride the ups and downs, I guess, of that change with the local authority teams. And lastly, whilst there's lots of knowledge and skills already in local authority teams, perhaps it's more about confidence to use those skills in a research context. And it may lead to people not wanting to be involved if they've not got that level of confidence. So I think some of what we can talk about today is about how we build that confidence. So just a few comments now on things that I think we have learned so far in first, if we move on to the next slide. I think we've learned a lot about the opportunity of bringing in external capacity. I mean, obviously that is at the heart of first, having a fully funded evaluation team, but also we'll be talking about the role of embedded researchers later in the seminar. I think there are opportunities about the capacity of other aspects of NIHR. We've already mentioned the health determinants research collaboration capacity. Locally in the Bristol area, we've also aligned some of the clinical research network local authority roles to FIRST, so that an embedded researcher funded through that route has been supporting applications to FIRST and working with the team to develop their ideas and encourage people to be involved in the research process. And I guess we could take that further. Be interesting to know how many of the FIRST projects are costing in local authority time in terms of their roles in the project. A second area is around local relationships. I think this perhaps more addresses the confidence issue. I think there are perhaps more opportunities to develop the relationships between the local FIRST teams and their nearby local authorities. I think where that happens, it's a really productive relationship where ideas can be shared, early ideas for applications can be discussed. So the more we can develop relationships between the academic teams and the service teams, I think that would be really worthwhile in building that confidence and embedding capacity. So just on to the next one. I guess there is something about building in resilience into the FIRST process. I've described a lot of the change, and we can put a huge amount of effort into perhaps supporting or working with one person in a local authority and they move on. But I think there's a lot of opportunity to build in more resilience, perhaps have more people named, and perhaps bring more junior team members in the local authority to play a greater role in the FIRST projects. And often they're people who've got more time, but are also at a point in their career where they're really keen to develop new skills and to embed these sort of really foundational research skills as well. And then I was just going to mention about more formally training, and we'll be talking about this a bit more in the seminar, the potential to embed more, I guess, formal training in the FIRST work with local authorities. For example, maybe around the framework for developing and evaluating complex interventions. So there's a shared language about how we're thinking about intervention, development and evaluation. Potential perhaps to extend the training offer, integrating it a bit more with other NIHR infrastructure, for example, the ARC training courses, and how we can use those alongside the FIRST work to help people build their skills. I guess there's perhaps opportunities as part of the FIRST projects, and many may already do this, to leave a legacy of evaluation frameworks for projects going forward after that particular project finishes. What could the local authority continue to do in their own evaluation, and perhaps working to build that sort of those skills and put them in place during a project. And finally on this, I just wanted to just bring in the sort of thought about public health training and registration. In any local authority team, there will be many people who are on training programs of different sorts or working towards registration, either as public health practitioners, public health specialists. In many teams, there are people who are funded to go on master's programs, maybe doing dissertations. I think the opportunities of FIRST and the capacity building in FIRST for people to use that towards their training and registration is a sort of win-win, and people can put time perhaps then more into developing those skills if they're using it as well for their training and registration. So just the last slide, just a sort of couple of final reflections. I think FIRST is I sort of think of it almost as a bridge between academic and service public health, with the shared goals we have, but also that people in local authority teams will perhaps sit along a whole spectrum of that bridge in terms of where they're going to be working in a research context and what their career ambitions are. So we have some who are wanting to cross the bridge and move into academic public health. We have others who perhaps just need to understand a very small contribution that they're going to make to research, perhaps bringing in just one element that they need to build the skills over, and everything in between. So I guess I find that quite a helpful way of thinking about it, that not everybody is going to want to become a researcher, but everybody needs some role and training and skills to be able to deliver on that role in a research context. So I hope that those sort of ideas will be able to develop a bit further in the further bits of the seminar. As I say, we're going to be talking about embedded researchers, formal training opportunities. So I hope that just sets the scene a little bit as we look in those things in more detail.
Thank you so much, Jo, for that excellent presentation. Time. So we're going to go on now into the next section of the seminar and have presentations on two different models of capacity building. And so our first presentation is by First Fusion, and Jenny Gillespie and Peter van der Graaf are going to present now. So over to you both.
Thank you, Ronan, and thank you, Jo, for that excellent scene setting. Good morning, everyone. My name is Peter van der Graaf. I'm a member of the First Fusion team, and as Jo and Ronan said, we're talking about one particular model we developed within First Fusion using embedded research as a part of the projects we're supporting and conducting with local authorities. Next slide, please, Cobus. So, as I said, we use embedded researchers as one way of capacity building, and we define that as co-locating researchers within sort of non-academic organizations, in this case, predominantly local authorities, to better link research and practice. And Ronan mentioned sort of the community garden as a way of looking at capacity building, and similar models exist for embedded researchers. This is a model developed by Vicky Ward, where she also developed a sort of a visualization around a garden with different functions that embedded researchers can take in that process. So, for instance, they can act as a catalyst in using applied research, working with local partners. They act as knowledge brokers to facilitate collaboration and co-production within those networks. They also build capacity by undertaking and disseminating research, and they act as navigators in those stakeholder networks, developing and maintaining different working relationships inside the local authority and other partner organizations. And they're also an active team member, so they're involved in all stages of the research process. And I think we can add a new role in terms of translator from Jo's presentation earlier. Next slide, please, Cobus. So at the moment, we're supporting 7 different projects, and you can see them on this map, and in all of them there's embedded researchers in those projects, some working in a particular service in one local authority, some working across different local authorities and sort of being jointly hosted by a university, and in one project in Tayside where the embedded researcher is employed, is working within NHS context, because public health in Scotland is not part of local government, and you will hear more from my colleague Jenny Gillespie later about her experience in that project. Before we go to Jenny, I'll do a little bit of scene setting about the project in Tayside. So next slide, please, Cobus. So what we're doing in Tayside, particularly in Dundee, is an evaluation of healthy weight Tayside, which is a whole systems approach to child healthy weight. And what the local authority was particularly interesting is in evaluating that approach, how do key stakeholders perceive their role within that wider system? Can they see what they can do in relation to actions at different levels within that system? And the way we've gone about the evaluation is starting with some stakeholder interviews to understand their experience and role within that system, but then train some of those stakeholders as peer researchers to talk to their colleagues about their experience and gain deeper insight in their role and experiences within the whole systems approach, to be developed in a survey that we could use to test it out among a larger scale and wider networks, and that's part of the legacy, so they can repeat the survey to keep track of how they're doing and performing going forward, but ultimately to inform a number of action learning sets with key stakeholders to look at how to take recommendations forward from the research findings, but also how to apply some of the findings to other local authorities in Tayside who are keen and interested in working in this way. Next slide, please, Cobus. So here's some references if you're interested more in the embedded research model and the way we work, and we rely heavily on the work of Mandy Cheetham within Fuse and Vicky Ward and colleagues. So feel free to have a look, and if you're interested in the embedded garden, the embedded research website is a good starting point. But at this point, I will hand over to my colleague Jenny Gillespie to give you more insight into her role as an embedded researcher in NHS Tayside. Jenny, I think the floor is yours.
Thank you so much, Peter. Thanks very much for the invitation to come along this morning and present a little bit around about sort of my role as an embedded researcher, which is very much supporting the academic team in the evaluation of our approach in Dundee. And as Peter alluded to, the public health landscape north of the border is fundamentally different compared to England, in that here public health sits within the NHS and not local government. So I work for NHS Tayside, which is one of 14 health boards in East Central Scotland, one of the 14 health boards across Scotland, which is located in East Central Scotland. And I'm based within the Public Health Directorate. So can you move to the next slide, please? So our project is evaluating the local implementation of the Public Health England's Whole Systems Approach to Obesity Guide. And Cobus, if you could just move through the first few animations, thank you. So what we do is we follow a 6-phase process. Some of you may be familiar with this guide because it obviously originated in England and has been rolled out in lots of local authorities in England. But initiated in Scotland in 2019, at the end of 2019, just before COVID. And what we were really interested in doing in our evaluation is to understand more about whether the implementation of our approach in Dundee will support our key stakeholders to recognise what they can do in relation to the actions that operate at different levels within the system. So Cobus, if you could just move through the next sort of 6 animations, just one after the other, and I'll just talk through. So what you're seeing presented on the screen now is really just some of the key milestones in terms of our evaluation process so far, which started in May 2020, when I was involved in sort of submitting an expression of interest to the NIHR for the public health funding opportunity. And that's really the starting point and the catalyst for what we will, I'll go on to reflect and talk about now as well. So moving on through, I suppose, our journey, we've been able to sort of meet with the and be allocated with the Public Health Interventions Response Study Team, North team, and gone through a process of sort of evaluability assessment workshops, developing the research protocol. And in January this year, that's when the formal embedded researcher role that I took on was sort of created and initiated there as well. So since then, I have had a little bit more space and opportunity, because whilst I was involved in sort of the expression of interest and supporting some of the earlier stages, the embedded researcher role has very much given me that dedicated space and time to focus on solely on the evaluation as part of my role. So we are currently in the process of going through our 4 work packages to address the research questions that Peter highlighted as well. And one of the most interesting aspects of this is around about the peer research aspect of our evaluation approach. And we have now got 9 peer researchers from a range of organisations within our local networks who are involved in sort of taking forward elements of our evaluation as well. So what they're going to do is interview individuals within their social networks about their roles and perceptions of the implementation of our wider whole systems approach methodology. So Cobus, if you could move on to the next slide. Thanks very well. So what I'm going to do now is just really reflect on how sort of research capacity has been enhanced through my own personal experience as an embedded researcher, but also through this peer research model that we're starting to sort of develop at the moment as well. So if I start with my embedded researcher role, and as you can see, I'm going to just simply give some examples of what I feel has gone well, what perhaps hasn't gone so well, what I would change, and what might be the key learning and improvements, and just bringing to life some of the local examples. So in the first 6 months or so of the evaluation, so we start with what I feel has gone really well. So before I was had the opportunity to take on the embedded researcher role, so I was involved in supporting the evaluation process and the evaluability assessment process as well. I didn't really have the dedicated space within my role to prioritise aspects of evaluation over the many other operational activities that I was sort of delivering in order for us to follow the whole systems approach 6-stage methodology. So the embedded researcher opportunity enabled me to dedicate 0.5 whole-time equivalent of my time solely to the evaluation. And we began to have regular weekly meetings with the research team. And then we were able to drive forward activities really needed for each of the work packages. So absolutely fundamental to where we're at the moment is the opportunity for me to have that dedicated space and capacity to take that forward and build those relationships with our wider networks and stakeholders. However, part of the challenge in my experience and my role has been that I have been both the embedded researcher on the evaluation and at the same time also continuing to implement the 6-phase methodology of our approach. 0.3 of my time is spent on that. So that's been quite tricky, but was necessary so that there was actually an approach to evaluate, because I was one of the people that were really taking that forward. So one of the challenges for me personally has just been that that dual role that I've had, and ensuring that, you know, there's elements of my time are spent focusing on both of these things and juggling those different things and juggling the different, I suppose, conversations that you have to have linked to that as well. So something that I would change overall in terms of that whole sort of research and evaluation journey would be, I think, flexibility in the time frame of the project to better suit the sort of realities that are facing the NHS and our local authority partners on the ground in terms of, you know, our capacity and our resource. Because the building and the maintaining of relationships with my colleagues and with my partners to see the value of a robust evaluation is hard work, and it takes a considerable amount of time and effort, and we need to do that before we will have them on side and on board to contribute to the evaluation. So I think for me, very much sort of a bit more flexibility, and we were fortunate, and we were able to and were granted an extension to our project, really just to reflect that need locally to have a little bit more time to do this well. So a key learning and improvement for me personally, I think it goes back to the point that was made earlier about language and about the translation, and the role that an embedded researcher has there is so important. So there's something there about the ability to be able to find a common language, and that balance between sort of different academic terms, which is often jargon, and what is meaningful to local workers on the ground. And some of that is exacerbated because within our approach, which is a whole systems approach, we have a range of multi-partners involved in this. And often the language that is familiar to academics is different from the language that's familiar to local authority staff, to NHS staff, might be different as well, and to sometimes to our third sector organisations as well. So we don't always have a shared understanding about that, and for me that's fundamental, and to try and invest the time and to try and get that right. So now I'll just spend a few minutes reflecting on how I feel that the training that we have undertaken for a group of our peer researchers has further enhanced research capacity, and would invite Peter to add in anything to this as well based on his own sort of experiences. But effectively in the last couple of months, part of work package 2 of our evaluation, we have supported 9 individuals from a range of our local partner organisations. So that might be other colleagues of mine within other NHS departments, local authority staff within Dundee City Council, and they make some of them come from education, some come from communities team, and also Tayside Contracts, who are the providers of our school meals up in Tayside. So we have enabled them to engage in online workshops to become peer researchers, and the majority of our 9 researchers wouldn't have otherwise had an obvious opportunity to be research active. They all, interestingly, do see this as part of their role. They're not expected to do this over and above, you know, do extra hours to do this. They do see this as part of their role. And one really nice story from one of our peer researchers, who was somebody who'd had to have a little bit of research background in that he just completed his master's in public health. Attended our workshops for our peer researcher training, and part of this is for them to be upskilled and to be able to take part to facilitate interviews within their wider networks. And he is very keen to sort of take on an enhanced role beyond the facilitation of interviews in terms of the analysis of some of the data and looking at sort of the development of the survey that's going to be taken forward in Work Package 3 as well. So it's really, I think, for me, shining a light on the opportunities that come beyond just that embedded researcher role. What didn't go so well in terms of the peer researcher aspect of our work, I think, is time. If you think something's going to take a month, what you're really talking about is 2 to 3 months. And I think, again, that just reflects the realities of the multi-agency and multi-partners that are involved in our approach, and practical aspects such as being able to arrange mutually suitable times to attend, to hold workshops for all the competing priorities that many of our colleagues have at the moment. There were a couple of other practical challenges that sometimes, are a little bit overlooked. Some of the simpler things about IT challenges around about incompatibility. Often NHS and local authority staff have restrictions with IT access, and so sometimes the packages that are used aren't always possible, so you need to rethink that as well. I would also like to say that...
Sorry, it's Rona here. I'm going to have to ask you to wrap up if that's
okay.
Okay.
Apologies, yeah, I'll just finish. There's just the last sentence here. I just wanted to say that I think overall, I feel as though for me, I've had a bit more confidence in being able to explore sort of local opportunities to build research capacity because of my embedded researcher role as well. And I think I've been able to share locally my experience of going through the process of the NIHR expression of interest application and encouraging other people to have the confidence to take that forward as well. So yeah, so that's me finished. Thanks very much for the check on time.
Thanks so much, Jenny and Peter. So we're going to move on now to our second model of capacity building here, and that's working with a clinical research network. And this is work First Insight involving Tricia Jessamine, Christopher Hill, and Pranianka Bastanvada and Rosie Rowe from Oxford County Council. So over to all of you.
Thank you. Corbus, if I could just have the next slide, please. So yeah, I'm Trish Jessamine and I'm a researcher with First Insight working on a study with Oxfordshire County Council. And the study was about how we might encourage people who live in market towns to use active travel methods. And by active travel, we were talking about walking and cycling. There's been a lot of work on that in cities, but much less in market towns. So we wanted to understand if it was the same or different. The study methodology including recruiting residents to take part in focus groups and then take part in a company journey, either on foot or cycling with me, and we would do an interview along the way. And recruitment was really tricky for this project. So we don't have a target population other than people who live in these market towns. So we don't have a service user group or people who are involved in an intervention. In fact, it's even worse than that. We were actually recruiting people to take part in a study about walking and cycling who weren't interested in walking and cycling. So it was a challenge. So the study began in early 2022 and it was adopted onto the CRN portfolio, the Clinical Research Network portfolio, in May. And actually they've been really, really helpful in recruitment from the get-go. They did things like they delivered leaflets to over 2,000 houses in each of our towns about the study. They arranged for targeted Facebook adverts for people who lived within the geographical areas we were interested in. They arranged for local media stories in both the papers and local radio stations, and they linked us with the transport lead at Oxford University Hospital who shared details of the study for anyone who was commuting from market towns into Oxford. So it's been really helpful, and I'm now going to ask for the next slide and let Chris Hill from Thames Valley and South Midlands CRN explain more about his work.
Thanks very much, Tricia. So thanks for the chance to speak to you all today. I'm a research delivery manager within the Thames Valley and South Midlands CRN. So I'm responsible for promoting and identifying resources to support research across a number of health areas, and public health is one of these. So just a brief history really of the story of the CRN remit, extended remit to support research beyond the NHS setting, which is what we're traditionally associated with. So Chris Whitty was one of the driving forces behind the changes in 2018 during his tenure as Chief Exec of the NHR. At the point that expanded remit was announced, I and many other colleagues were kind of trying to engage in exercises to identify where to invest our really stretched resources. It was a bit of a guessing game. There's a massive remit beyond the NHS, and no one really had a clear strategy for narrowing down where that investment should be made. It was helped in 2001, 22 and 22 when with some recognition that we need some additional investment to make things work. So each local research network was provided with additional resource with the intention of greater support for social care, public health, and community-based research, which included local authorities. So just so you know that each local network did things slightly differently, but all were expected to establish a direct delivery team with the flexibility to cover research beyond NHS settings. So those teams are expected to be agile, but they never sat idle. Our own direct delivery team, for example, in the absence of any studies that might fit these criteria that they've been kind of like expected to cover, they'll be sat doing other things. They'll be doing other work within the NHS possibly until another study comes along which fits this remit that they're actually being funded for. And the understanding that we have with those teams in our region is that they should be made available within 4 weeks of a request for support. So quite often when I'm speaking to teams across the breadth of the non-NHS regions that I work with, I'm trying to encourage some planning further down the line so we can make sure that resource is available when it's needed. At the same time as the introduction of that transformation funding, each network was provided with funding to support local authority embedded public health research practitioner and consultant posts. And the remits for those varied quite a lot across the country, but a key remit amongst all of them was to raise awareness and provide bi-directional linkage between local authorities and the research networks. The support that was provided for the active travel project in Witney and Bicester was made much easier to identify, first of all, and to support due to having that established links in place. And Priyanka did quite a lot of the heavy lifting on the form filling and dealing with the CRN bureaucracy that I know puts a lot of people off during the adoption process, and she did a great job. In addition to these posts, every local research network also has an academic or a consultant that leads for public health, as well as having a research delivery manager like me. So we've got a particular focus on promoting and supporting public health research generally. And every local research network should also have someone like me with responsibility for linking with local authorities, in addition to those posts that are already embedded within local authorities that we've just mentioned. So if you're having difficulty linking in with research networks, these are the people that you need to try and link with. You need to try and identify them, and if you can't identify them, then please contact me. I'll help you to identify them for sure, because they're the people with a vested interest in promoting your work and making sure that it's delivered, because we've got just as big an interest in this as you have for sure. To note for future interest, we know this is the first of the first research projects that CRN adopted, and it was only during the initial conversations with national teams that we received confirmation that first funded projects were actually eligible for CRN adoption. Before that, there was definitely some doubt. So if you're interested in growing work with research networks in other areas, maybe some comms around that aspect in particular might be useful to make sure that you reduce the barriers that may be in place in other areas. The next slide, please. So the CRN is often cited as the delivery arm of the National Institute for Health Research. We don't fund research, we don't design research. We're all about giving hands to help with study delivery. And for appropriately adopted CRN studies, these are the kind of support offers that local networks can provide. So those highlighted in red are the ones that were drawn upon for the active travel project. We do, of course, have people, already mentioned, that can help with the practical aspects of study delivery. The support offer we normally provide is largely about identification and recruitment of people. But there's usually quite a lot of willingness to be flexible around this, especially if it's a priority area like public health. So it's definitely worth having a conversation about the type of support that you need. If we don't have the appropriate people in place, in the right place at the right time, it's sometimes possible to provide funding to buy out the time of an organisation's workforce as a substitute for the service support element that we're expected to provide. It's usually not a massive amount of money, but it usually helps as well. We're often acting on behalf of study teams to link through to sites beyond our own local footprint as well, to increase participation across the country. And if that's the kind of help that you need, we can also provide some support for that. There's usually some local initiatives around training or fellowships that we provide funding for. So that can also overlap with some of the help for study support. So we're often promoting things like green shoots support. So where there's no research going on, we want to try and pump prime some things, and that can be useful to tap into. If you link in with your local network, you may be able to get access to some of that. We also have other local research infrastructure that teams can tap into. We have a network of care homes that have agreed to receive information about research projects. And we have many GPs that receive sessional funding from us to support research. GP database searches are used by many researchers to identify participants. If the appropriate approvals have been in place for the active travel project, I think that option would have been a really useful one for future reference. We do have really active GPs.
I'm so sorry, I'm also going to have to chivvy you on a little
okay.
bit.
Okay, just to highlight the other things, so we got comms support, which was useful, training resources, and obviously the navigation of the CRN systems, which I think is probably a barrier that many people find a bit off-putting. It's probably one of the key things. So I was going to lead on to Priyanka, but if there's no time, I don't know what you want to do.
Priyanka, by all means, go ahead.
Okay, well then I'll keep it really short. Hello everyone.
Thank you.
I'm Priyanka Vasantavada. I'm the public health research practitioner based at Oxfordshire County Council, but I do work with Chris on the activities in the wider area as well. So I try to get the other local authorities in the CRN geographical area get involved in research as well. So my post primarily is to foster a sense of research culture in local authorities and try to get local authorities more research active. And incidentally, I started my job last year, and this first project pretty much became the starting point for my work. And it also became the starting point of making the Oxfordshire County Council Public Health team more aware of what support is available in terms of NIHR and what schemes are available and how they could get evaluation done. Because the most, yes, Thames Valley and South Midlands region, I am the research practitioner for that entire region. You would find that that I have around 20 odd counterparts spread across the various CRN regions, and most of them, I wouldn't say that everyone is based in the local authority. Some are based in universities and some are based in NHS Trust, but you could definitely find them. And they're all just as crazy as I am about research, so they would be more than happy to help you with your endeavors, whatever they might be. That's it. My work in this first project was that as I started my job, this first scheme came along, and we had a need in the Healthy Place Shaping team, and they wanted to evaluate the active travel project that was ongoing. So we found that the first scheme was pretty suitable for it because the application form is pretty short. So that makes it easier for local authorities to engage with it, because one of the barriers of engaging with research is that no one has a dedicated time to do research. And that's how this came across. And with the success that we have had with this active travel project, so far we have had a lot of interest in our local authority to apply for subsequent calls. And I must say that every subsequent call after the success of this project, someone or the other applied from our local authority. Successes, I can't comment on that, but at least people have started thinking about it, which I would say is a big boost for the research culture aspect of my job. And along with that, my role in this project specifically has been to help the local authority team put the application form in for the first scheme, and also bring in the CRN support just when Trisha's team got the ethical approval for the project. And do the work for getting it on the portfolio. And the CRN team was incredibly supportive. And I would encourage everyone to liaise with their local CRNs and try to get their projects onto the portfolio. And thank you. I would like to pass it on to Rosie, who would probably discuss more about how it was helpful for OCC in general. Thank you.
Sorry, but I think we are going to have to sort it here because we're now 5 minutes over the timetable. I'm so sorry, Rosie, to cut you off, but I think people can there very clearly the advantages of FIRST and CRN involvement there in the slides. So we are now should have had questions, but we're now meant to be going to a break, and I think we're going to have to save the questions till the end that we might have taken now in order to have the break that we promised. So I think it's important to have that break. For some people need that break particularly. So if we can just take a 5-minute break now. Well, welcome back everybody. We're now going to go into the second section of the seminar where we're going to look at a further 2 models of capacity building and specifically looking at recruiting and training of partners. And our first example is going to be presented by Dr. Kate Newby, who works with First Connect. So over to you, Katie.
Thank you. Morning, everybody. So my example relates to the training of 2 individuals within an organisation that we were evaluating as part of one of our first projects. And what we really wanted to do was to leave a legacy of qualitative data collection and analysis skills within that organisation, and to provide some hands-on experience of qualitative data collection and analysis, and also for these individuals to feel invested in and to feel valued as part of our team. And so the training ran alongside the project, and they had an opportunity to directly contribute to it. So first of all, a little bit of background about the particular piece of research, so you can understand where these individuals fit within the organisation, and also how the capacity building element of it also fitted in. So Cobus, if you could move along to the first slide, please. Thank you. So our evaluation was of an exercise referral scheme, and just so everyone understands a bit about what exercise referral schemes are. So this typically involves a patient being referred to a programme of exercise sessions, usually delivered within a local authority leisure centre. They get referred often by a GP, but can also be another type of health professional, and are expected to regularly attend a number of sessions over a series of weeks. And in our case, the evaluation was of the Welsh National Exercise Referral Scheme, also called NERS for short. And it's delivered across the whole of Wales, across all 22 local authorities. And the remit for being referred is that individuals need to be over 16, sedentary and or deconditioned through inactivity, and are at risk of or currently experiencing a long-term condition. The programme's been delivered since 2007, so been going for quite a while now, and referral for the NERS is indeed by GP, but can also be a health professional in secondary care as well, such as a dietitian or physio. And in this case, the programme is 16 weeks long. It's delivered in practice by specialist exercise instructors. So these deliver the exercise classes, and they're referred to as exercise referral professionals, or ERPs. And these ERPs are managed by a team of NERS coordinators. And because it's delivered at a national level, there's a requirement for some operational and strategic oversight. And this is performed by Public Health Wales, which is a national level organisation charged with improving and protecting the health of all Welsh citizens. So next slide, please, Cobus. So the aim of our particular study, well, actually, I'll come on to that just in a second. So during the COVID pandemic, it was necessary for NERS to move to virtual delivery in order to carry on supporting its service users. So our particular study aimed to examine the impact of that change in the type of delivery on NERS, so that Public Health Wales could make some decisions about whether to continue to deliver that type of delivery in the future. And we had two work streams. One was quantitative in nature and the other one was qualitative. So the quantitative one examined routinely collected data to understand the effect of different types of delivery on programme uptake, adherence, outcomes and costs. And then there was a qualitative study that explored stakeholder views and experiences of the different types of delivery. We had interviews and also focus groups with the ERPs. And for the focus groups, we had 3 in total with 19 participants. Next slide, please. So the training was devised and delivered by my colleague, Nigel Lloyd. As you can see, it was pretty comprehensive. I haven't got time to go through all the individual elements, but if you want to ask me any questions about that afterwards, then please do. But next slide, please. So in advance of the presentation today, I asked Public Health Wales if they could give me a quote for the presentation today on what they saw as the value of it. So I'll just read out the second part of it. They say Public Health Wales value this aspect of the first project and the opportunity to further enhance the skills and development of our nurse staff across Wales. We aim to utilise the skills and experience gained to support stakeholder engagement and user feedback to inform the ongoing development and delivery of the nurse programme in the future. And then also, if you go to the next slide, Cobus. One of the 2 exercise referral professionals that we trained in qualitative data collection analysis, they provided a written quote, but also some audio. So the quote has the same feel to it as the audio. So if you can just play the audio, please, Cobus, then we can hear what this person has to say.
My name is Shelley Jackson and I'm the coordinator for PAWIS of the Wales National Exercise Referral Scheme, and I want to share with you my experience of working with the FIRST research team in the capacity building of the National Exercise Referral Programme. Now, this all began in light of the COVID lockdowns and the impact it had on the exercise referral scheme and how we had to adapt so quickly to be able to move forward and support our participants in the future. I was very fortunate to be invited and take part in the workshops for the capacity building. And this, to me, I felt it was incredibly well structured. We had the opportunity to look in depth and have the understanding of the quantitative research and facilitating focus groups. We also had practical sessions of those focus groups and understanding how to analyse and be able to plan sessions and apply this into NERS, and from that be able to continue looking into the coding and how we'd be able to come up with the results from those focus groups. For me, it gave me the confidence to be able to apply that at a very local level, to move on and look into other projects that we may actually be involved with. It also gave me the confidence to include our participants and how that could be structured. Also involving my team and how that could look, and be able to have the confidence to take that forward, really. The team are incredibly supportive, understanding and very reassuring. Even though you may have doubts in yourself in the beginning, I found I learned an awful lot from them, and I do believe it was an incredible, lucky opportunity for myself, and it's something that I will hold quite close and be able to take forward in my management role. And I'd like to say thank you, and I hope that you can benefit from the opportunity too.
Yeah, thank you. If you go on to the last slide then, Cobus, or the last 2 slides.
Hello,
actually.
my name is
I'm going to whiz through this to finish on time, so I might not get to say all these different things, but Nigel and I talked ahead of this on, we made some reflections. So I've got some best practice challenges and lessons learnt. So in terms of best practice, we reflected that it was a good idea to invite expressions of interest rather than actually asking leaders to identify particular people, so the people who come to you are already interested and committed, to be very clear about the time commitment, but also to be flexible, again, to ensure that people are kind of engaged and willing to stay with you right to the end, and so that you can benefit from them and vice versa. To allow plenty of time to lay the foundations of understanding about what research is. We found that really important, and Jenny was talking about that shared language, spent quite a lot of time coming together to develop that shared language, understanding terminology, understanding the difference between quantitative and qualitative research, for example. Best practice as well about making sure that you don't teach those people in the local authorities to use tools that aren't available to them in practice, particularly pieces of software that you use within academic life. Challenges, it was very time consuming, both to prepare the materials and to deliver it. And I wonder if there's an opportunity maybe to share those resources across the FIRST teams, maybe to open up our training sessions to other teams, or to share the recordings of them afterwards. Next slide, please, Cobus. And in terms of lessons learned, again, as Joe pointed out, there's a real need to build confidence. We found that the two people we worked with, as keen as they were, they needed quite a lot of help in order to build that confidence through practice and feedback, but it was well worth that investment. And the primary purpose was to build capacity in their team, but actually we benefited from it greatly. It helped to break down the power dynamics at data collection. It provided that link between the people who are participating and ourselves. It aided transcription, because there were some bits that our professional transcriber of our focus groups couldn't work out, and they could. Also added some rigor to our analysis through their additional voice within that and their understanding and reflections. But a last point is, I feel that their voice within our work could have been more fully realised had they been able to commit more time to it at the end. So they coded some focus groups, but they could have coded more if they'd had time. And also we would love to have got them involved in the interpretation sort of level, but there wasn't time to do that. And I wish we'd built that in at the start. That's it from me. Thank you very much.
Great. Thank you very much indeed, Katie, for sticking to time and a great presentation. So our second example in this strand is going to be presented by Thomas Mills. So Thomas, over to you.
Thank you for inviting me. So my presentation will explore co-inquiry as a way to involve a wide network of local authority public health staff in research. The co-inquiry explores the question how to reach underserved communities. Thanks, Cobus. To set the scene, the co-inquiry is just one work package of a broader evaluation. This evaluation is led by Professor Lynn Dawkins of London South Bank University, and the local partner is a stop smoking service that spans Bedford Borough, Central Bedfordshire and Milton Keynes. I'll refer to the local partner from here on as BMK. And the core research question of the main evaluation is exploring the effectiveness and acceptability of a telephone smoking cessation service compared with face-to-face consultations. And there was a link in the chat earlier to that. The shift to telephone delivery as the core mode of delivery during COVID-19 presented something of a quasi-experiment that the main evaluation is exploring. But it was apparent during the kind of early discussions with local partners that while they were mostly interested in exploring that shift, they had a lot of interesting outreach work going that was just kind of ramping up after the COVID lockdowns. And these were developing in real time, and they weren't actually captured by that core evaluation question. This was the team's efforts to go out into communities to raise awareness of the service and to facilitate referrals into the service among people from underserved communities who smoke but aren't necessarily engaging and perhaps aren't even aware of the service offer. Thanks, Cobus. So there's a lot of interesting outreach going on, a general kind of lack of research in this area, and that question of how to engage hard to reach or underserved communities is of course one that is really quite pressing across all public health services. So all this equates to a research opportunity. And through the early workshopping sessions, we therefore developed a kind of secondary research question, which was how can a smoking cessation service enhance engagement with underserved communities? And the primary method through which we would explore this is co-inquiry. So BMK staff, not just the small number of senior staff involved in the development of the evaluation plan, but the wider team. We currently have 14 staff members feeding into this, doing things like attending co-inquiry sessions and also completing reflective diaries. So I'm also a participant and I'm observing some of the outreach events and pushing out alongside them to interview members of the target groups. So I've actually created a model of this to show how we are working together. So the inputs include the staff experience and reflections. They bring those to the co-inquiry sessions. We planned 6 of them. And these sessions run alongside staff's outreach work. So that's at the top. So this is very much kind of fitting alongside staff's work and tries to fit into their busy work schedules. So what they're doing, they would have been delivering the outreach anyway, but we're reflecting on them in those co-inquiry sessions, and they're capturing some observations in regarding how they're working in their reflective diaries. Now they send those to me. I'm another input. I'm the first researcher, and I'm facilitating those co-inquiry sessions and doing preliminary analysis of the reflective diaries, also analysing the data that I'm collecting. So at the bottom there, I'm undertaking observations of the outreach events and interviewing members of underserved communities. And in the co-inquiry sessions, we reflect on how things are going. So that's a core kind of activity. Our reflections include just discussing what events are working best. We've tried out different areas and targets: primary care, working with housing associations, targeting supermarkets, and we talk through how can we attract people to the events, how do we expand the reach through leafleting or radio campaigns, and also what do you say to people who it's a different dynamic to what they're used to. This is a different dynamic to a consultation where someone has already decided, well, actually, I would like to quit. So how do you have that conversation with someone who hasn't actually made that decision yet? And it's interesting, we're kind of developing a notion of kind of person-centered outreach. There's a lot of person-centered consultation models, but not actually outreach. It's a kind of different dynamic to the consultation. We're also refining data collection approaches so that the staff have that template to capture their reflections. And this we've reflected on and refined over the course of the process to really capture what we think we need to know. And we're making sense of that data as we go through. So again, I do initial analysis and I take interesting sections of people's diaries or interesting quotes from the interviews and bring them to the group. How do we make sense of this? What did this tell us about the outreach work, and how might we refine them to improve what we're aiming to achieve? And all of that is feeding into a logic model of the outreach work. So the outputs, this is very much kind of feeding back into the work that they're doing. And I'll discuss some areas where I think it's actually kind of had an impact there in the next slide. We have that model of successful outreach in what is an under-researched area, and we hope to generate learning for stop smoking services elsewhere in the wider public health community. So I should say that this is very much live. We're about 4 months into the 6 months plans, and this was going to be, we had actually kind of fast-tracked to get this through the ethics and get this up and running, and it's kind of a precursor to the main evaluation that starts at the end of the year. Thanks, Cobus. So just some reflections. So impact on local research capacity. It's about too soon for feedback from staff. I don't have, Katie had some really nice feedback in her last presentation. We're not quite there yet, but I think we're definitely going to try and capture systematically how staff have found this. There is high engagement. I've actually tried similar approaches to this on busy hospital wards and some other local authority services, and have had very little luck. It doesn't fly when staff have no capacity. So that does raise questions about its scalability, and also, I should say, local leadership. And there's a really strong team here that is quite unique, I think. But staff appear to enjoy the process, and having that time to reflect on practice, be involved in some kind of systematic research processes, can only be a good thing to spread kind of evidence-based practices. And that logic modelling process that we go through, I think it was Jo in her presentation earlier talking about the importance of kind of embedding a sense of intervention and development in the different stages to that. Of course, logic modelling is part of that. Some of the insights, personally, as a qualitative researcher, this is a new area for me, so it's really helped me understand the context and the issues ahead of the main evaluation, because I'll be heavily involved in that main evaluation. It's also generating learning, which with local and national import, so that sense of person-centred outreach and the model underpinning it. There's been examples of refocusing the outreach away from general practices to supermarkets and shopping centres, and kind of tweaks to local data collection to systematically collect where service users first heard of the service offer. So we have some, the team has some kind of ongoing data to kind of reflect on and think about what's working in terms of their outreach, which will continue and is always adapting and changing. And actually, as well, this co-inquiry, this forum we've set up, we're talking about actually this could be a really useful mechanism to feed back the main evaluation findings when that actually feeds in, and we're planning to actually extend it through that main evaluation. It's a way to kind of involve a wider network of staff in that. Just generally, the outreach field, there's a lot of quite linear approaches, but this field is really quite fitting here, and it fits the kind of messy reality of service delivery and how we're coming in. It's very formative, all occurring real time, and also, I think, importantly, kind of tries to not impose a lot on the staff. They're attending meetings and doing some kind of reflections on what they're doing, but much of the work is kind of carried out. Yes, that's it.
Great, thank you so much, James, and thanks to all our speakers. Okay, so we're moving into the final part of the seminar, and that's time for some summation. So Tricia Jessamine has been monitoring the questions very carefully as they've been coming in the chat, and there seems to be 4 kind of key questions that have developed. And so I'll go through those and ask various people to try and respond to those. So the first question is about the degree of overlap and or synergy between work of FIRST teams and the new health determinants research collaborations that James mentioned in his introduction and have been referred to. So I wonder, James, if you are able to perhaps offer some reflections on that. And I think I also saw that Brian Ferguson was attending, and I wonder perhaps then if after James speaks, Brian might like to say a few words on that topic as well. James, are you okay to speak on that?
Yeah, absolutely. Thanks, Rona. I'm not sure Brian is still on the call, but I'd echo the point that I think Brian made in the chat, which is that the intention of the 2 schemes, so FIRST and HDRC's, the Health Determinants Research Collaborations, is that they're very much complementary. So it's probably worth emphasising that the HDRC funding isn't research funding as such, but it's infrastructure funding. And so we as NIHR would then sort of encourage HDRCs to apply for apply to FIRST calls for expressions of interest in due course. So I think that's one way in which the schemes kind of work synergistically. And so yeah, I'd very much echo Brian's comment on that.
Great.
Rona, I'm still here if you want me to comment very quickly.
Please do, Brian, please do.
Thanks, Rona. And I'm going to add really to what James has said and what I put in the chat, but I thought it might be worth just emphasising to people on the call, as I put in the chat, that we've got, we've now got over £70 million of resource to work with here. So it's incumbent on us to get value from that and to not duplicate. But probably also worth saying that, again, many people on the call know we're planning to expand the first team in the next year to move from 6 to 10 teams. That's the plan. And we're also hoping for a second round of HCRCs in the spring. So there'll be more to look out for that. And just to flag, there is a webinar on HCRCs. James and Helen will correct me, but I think it's the 17th of November, but we can stick details in the chat if that's helpful.
Great. Well, thank you both very much for answering that question. And the second question that's come in is about the role of using local stakeholders as researchers, and does that impact the results? So I think that's possibly, but someone could correct me, about whether it's maybe too much of a case of poacher turned gamekeeper. Is that an issue? I think that may be what's behind the question, and I wonder if any of our speakers today who've obviously been working very much in that way want to comment on that, because I can certainly think of some of my epidemiological colleagues who would definitely ask that question. I hope I'm interpreting it correctly, but would any speakers who've been working on that?
Yeah, I could come in here. Potentially Peter might be able to come in as well. Yeah, I absolutely take that point, and I think what was key for us in our sort of evaluability assessment process in terms of co-producing what our evaluation approach was going to be was basically that our research design was agreed by sort of local stakeholders during that process. And that actually pointed to the importance of involving key stakeholders to work alongside the research team to conduct the interviews. So it was something that sort of came through sort of our evaluability assessment, and I think there was I think it's trying to strike that balance, isn't it, between there being potentially more trust in somebody who you're interviewing, perhaps making sure that there is more honesty in the responses. I'm not sure if that answers exactly the question, but I think that might give you a little bit of context in terms of what we were doing in Dundee. And Peter, I don't know if you want to come in at that point as well.
Thanks, Tony. Yeah, just building on your response, we see it actually as a strength. So it allowed us, by using peer researchers, to find people in wider networks within the whole systems approach that we wouldn't be able to access as research team members ourselves. And that relationship of trust that the peer researchers have with their colleagues enabled them to recruit other participants for the interviews. And that there is a question about how does that work in terms of bias. So what we, as part of training, we encourage peer researchers to keep a reflexive diary of their experiences of doing the peer interviews and understanding sort of their own perspectives they brought to these conversations. And we take that back into some of the conversations we'll have afterwards in the debriefing with the peer researcher. So hopefully I think that will use the insights, and it's a strength instead of a challenge.
Great, thank you very much indeed for those very comprehensive answers, Jenny and Peter. So a third question that's come up is, and I can share this as a Scotswoman who has spent time living in Northern Ireland and has worked and collaborated a lot with people in Wales, as well as obviously being based in England. Much of what has been spoken about is about England. And I guess that's particularly probably perhaps thinking about clinical research networks and so on, if those are not part of the landscape in Scotland and Wales and Northern Ireland, where the public health structures are different. And I think there's been a lot of language has been a thread throughout this seminar, I think, and I guess that's something that is perhaps not so much a question, but it's something to bear in mind, that the landscapes in the 4 countries are different with regards to public health practice. And that's something that we need to bear in mind in terms of thinking about capacity building. So I think that's possibly not so much a question, but a point. But if anybody wants to speak to that, please do say something now. I think it's a very important point that we all need to to bear in mind things are not the same. And of course, that is also an opportunity in evaluation terms when things are different. And so that's something that perhaps, I mean, that we perhaps can think about in terms of as a collective of first teams, how do we address that, and how do we overcome that, and how do we pay attention to that. So thank you for pointing that out as we all hear that. James, you want to come in on that?
Yeah, I think Rona, just on that. So I think one, I think as NIHR, we've been sort of conscious of using the most appropriate terminology when it comes to this. So local government, so using the term local government, perhaps more so than local authorities, which can be a little bit England centric, is something that we've been conscious of. So I think that just speaks to the broader point that language is so important. And I was really interested to hear the comments and the reflections earlier in the session on the use of plain language as well. And often it's just so much better to express things and easier to express things in plain language to make things understood. So really interesting reflections.
Great. The final question that I've got down here was about sharing resources across the different NIHR structures that we have. So we've talked about first teams, obviously we've talked about HDRCs, and we've talked about academic research collaborations, ARCs. I mean, I think there is an attempt to do that already on the NIHR website to share lots of things, and obviously we all do have our websites, but certainly again that's something we can take away and think about whether we're doing that adequately or not. But I think we've just got a few minutes left, so I just want to offer some final reflections, if I may, and try and summarize some of the things that we've been saying today. I think first of all, what I've been hearing is that the FIRST initiative is highly valued by local government and by partners both in the voluntary sector and members of the public. And we've had 4 fabulous examples of different models of capacity building today. Thanks to everyone for the very clear explications of those. We've heard about a need to build confidence in local authorities to even submit evaluations for first team help, and I think that's something that we take away from today. We also had a suggestion about embedding more formal training in order to tackle this issue of a shared language, and there was a mention of the MRC, I think the MRC framework, and that's something I think we can think about collectively as a group. First, what would that training look like? There was also talk about the value of leveraging capacity, both in terms of people working in public health practice in local government, and also obviously in the NHS and in Public Health Wales and other bodies, and from public health trainees, and also resource from clinical research networks, although taking the point that I think someone made in the chat, there are some changes envisaged around that kind of support in England, certainly. We heard about the need for flexibility and for time being allowed in evaluations, and particularly because it takes time to build confidence and trust and relationships, and particularly and making the case, as it were, for the need for that and the understanding for that. And then we talked a lot about language today, and the need for a common language and for language to be meaningful for lots of different people. And again, there needs to be time to attend to that and to be able to have that communication, and also the need for translators, and perhaps some examples today of how embedded researchers fulfill that kind of translation role as part of what they do. If I may, I think one of the things that perhaps we didn't get to talk about as much as maybe we should is where the public and our public members sit in all of that. So for me, I think there's an issue about that. Cobus, if we can just move to, yes, very sorry, just hold on that note. Okay, go back. Sorry, yes, I just wanted to say that there is lots of training available and capacity development. The NIHR Academy is something that provides lots of that. Can you go to the next slide very quickly? You also have a public health incubator, and we're about to launch a website which is going to help people be able to find all of the different kind of capacity building opportunities and training opportunities that there are within public health research. And then Cobus, if you can go to the last slide, thank you. I can't talk about all the other things I was planning to, but what I did want to do finally was just to say to thank you all so much for all the input this morning. Thanks to all our speakers, to all our participants and the colleagues who've helped to make this possible. And to say on the subject of patient and public involvement, that is going to be the theme of our next seminar, and at First Connect we'll be hosting that. I also want to say that the deadline for expressions of interest from local authorities for evaluations, the next deadline is at 1 p.m. on the 31st of January. We have a first website which has lots of information on it, and that the web link for that is there. And if you want to tweet about our events, then please use the hashtag first. And then if you want to follow us on Twitter, the details are also there. Okay. Thank you all very much indeed. But I look forward to seeing everyone at the next one.